So I wanted to thank everyone for coming, welcome you to our Testing COVID webinar between Polaris, Department of Commerce, and the Department of Health. And Happy New Year, I think I can still say that. For those that I haven't met, I am Kathy Mahoney, and I'm the new Center Director for Polaris MEP, and I'm excited to be here in Rhode Island. Thank you to the Rhode Island Department of Health and the Department of Commerce for organizing this event. We have been reaching out to the manufacturing companies, and they have been thrilled. But as you can imagine, with any kind of process comes questions, especially for manufacturers. We like our process. So this COVID testing program is a terrific resource for manufacturing companies, and it'll also help keep your employees and Rhode Islanders safe. So we are thrilled to be the messenger to the companies for this program, and we welcome Bill Adler and Jillian Balzano from Department of Health and Commerce. And if anyone doesn't have any questions for me at this point, I'm going to turn it over to Bill from the Department of Health to go through the program and hopefully answer all of your questions. If there's a question that you think of after the event, feel free to email me. Most of you should have my email address, or just call the Polaris MEP office, and we will certainly get that question answered for you.
All right, so I am going to share my screen this time, which is right here. Can you guys see the slideshow? Is that what we're looking at?
Yep.
All right, well, here's the front page of it. And I'm going to let Bill take it away.
Okay, hey, thank you very much for the introduction. Bill Adler, I'm a project manager with working with the Department of Health to deliver testing, primarily or previously in the K through 12 higher ed and childcare space, but I've recently moved over to delivering testing to employees and different population groups across Rhode Island. And this nests with our broader effort, and this kind of goes into the overview and how does this effort fit into the big state program. So what we're seeking is complementary effects, and those effects are not just public health effects, which we're all well aware of, in reduced prevalence and early intervention, but also confidence, public confidence that testing is widely available, accessible, and will help not only keep parts of our economy functioning, but also protect the wider community. And that's where we see converging efforts as areas that we want to throw resources into. And converging efforts are not just what we're used to hearing, which is in terms of just K through 12 testing or just testing at colleges, but also really community-based testing. And when we talk about community-based testing, that includes our employers, because our employers, as we've discovered in watching this disease in our intervention efforts, is where many people encounter COVID and then expose it or share it with other members of the family. So if we can intervene early, we can shut down outbreaks, and this is positive economic outcomes along with public health outcomes. So now we have some tools on hand to help us do that, and that's really where Binax comes in. So the federal government's pushed over 1 million tests to the state, and we're able to use these tests to rapidly result asymptomatic and symptomatic patients in the field without a lot of back-end technology. So unlike what you're normally used to seeing with testing at testing sites with the nasal swab up the nose that goes off to the lab and you hear in 24 hours, these tests allow us to rapidly result within about 15 minutes. Very easy to use, and because they're simple, a lot of times over age 12 they can do self-swabbing, and that increases the safety for folks involved in the entire process. So really that's kind of the start point and how we'd like to get into this. And what we can do is go forward and talk about how we can deliver that to your workplace, what sort of resources we can provide, and what the onboarding process might look like for you. Great transition. So what the business does, there's some asks that we have of employees or partners who use the Binax Now test. One is a personnel commitment. So identify people, volunteers in the organization who can help facilitate testing. And I'll talk a little bit more in detail about what that entails as we get into this and hopefully answer your questions. And then two is develop a testing schedule that regularly tests your employees, i.e. 100% is the goal, but there's a few different ways we can get after that depending on the size of your organization and the context of your workplace. And then the third component really is that reporting piece. And that's essential at the back end of the test process because it allows us to do contact investigations and tracing for positive cases, but it also supplies us with some data that allows us to see and anticipate changes in prevalence in communities and then do some downstream assessment about where resources need to go in the future. And to help you do this, the state has a very deep supply of tests. As I mentioned, over 1 million right now sitting at the Dunkin' Donuts Center. The federal government has supplied these to us, and there's no cost associated with using them. We also have the resources to do training and onboarding, and that can be in-person training or in some cases virtual training or webinars for use of the reporting tools. We also, through the state, manage the QI and QC process. So based on the reporting back to us, the state has continued to build out its backbone of case investigators and tracers that will follow up on positive cases and also provide public health guidance based on the latest recommendations from the CDC and the Department of Health. The back end of the testing is a requirement to use appropriate disposal methods, and we've discovered that this is includes the use of biohazard bag and boxes to dispose of these. It's a pretty simple setup, but there is a cost associated, but the state assumes that cost. The cost is not transferred to your organization. So most of our partners develop, once they figured out how to use the test and how simple it is to use, they look across their workspace, determine who they're going to test in their employee base, and then how they're going to get after that testing based on the work context, whether it's a manufacturing site, a construction business, or retail. Some of the recommendations that we have seen work in multiple contexts is randomized testing, which is really true surveillance testing where you're doing a proportion of your workforce every day in small bits to get after that goal of 100% or everyone in work, in the workspace tested. Another approach worth considering is affinity group testing. And this is testing of groups that are interrelated, in close contact frequently, and therefore most likely almost like a pod. If you're familiar with K through 12 testing, that's how a lot of our schools reduce the impact of a positive case is by grouping students together. And I know some workplaces do similar things. And so affinity group testing is one way to pursue that. Staffing for this effort is fairly small. Because it is a self-swab test, what you're used to seeing at a field testing site with clinicians gowned up with face shields and masks and gloves, multiple layers of gloves, isn't really needed in the workplace for a self-swab. You do need to have somebody who is trained to be an observer and a recorder. And so that's a minimum of 2 people, probably for the workload in most workplaces. This allows you to result the test, have somebody who's trained to interpret the results, which is fairly simple, and also record it and pass that information back to the state. And then we recommend more than two people for this because it gives you a little more depth in case for some reason an employee is out for a day, or, you know, God forbid somebody comes down positive. A little depth in your team will allow you to continue your testing effort. The training for this is in terms of an investment, is probably about 30 minutes to an hour of time to get somebody prepared to do this reasonably well. I'll pause here if there are any questions.
I think we have the next page is kind of like what we do next, but in terms of the basic, we can talk specific examples too, basic layout, testing cadence, and reason why we want to be doing this. Are there any questions in that space that we should field now before we get into, okay, how do I sign up?
My question concerns accuracy of the testing, right? I've had this a couple times. I don't know if I could actually stick that swab up my nose that far by myself.
Great. Hey, that's a great question. So let me fill you in on something we did in December. In December, we did side-by-side testing in schools with Binax and the normal PCR swab. And these were administered by clinicians in most cases, although we had adult faculty and staff self-swab. The test, like if you go to the Wickford train station or some of our other testing sites or a hospital, the swab tends to go a little further back in your nasal cavity, a little less comfortable. And that's what most people associate the test with. And that is a PCR test that goes back into a tube and gets resulted at a lab. The Binax test is in the forward portion of your nasal cavity. And we found that most kids are used to sticking things in there, so it was fairly easy to get them to do that. And that is the sample that is taken out of both nostrils and then resulted in a credit card sized test card. So think of it as a home pregnancy test. The process is to open the card, deposit there's a fluid that is deposited in the well, specimen well, and then the sample taken from the nose is inserted into that card on the swab. Then the card is closed and the resulting period is 15 minutes. During that 15 minutes, the fluid reacts with the specimen, and you either have one pink line, meaning a negative test, or two pink lines displayed, meaning a positive test. So fairly straightforward in that regard.
Right. So by design, the Binax test is not the deep nasal cavity.
That is correct.
No, it's good to know. I didn't know that.
Yep. As for accuracy, the reason we did a side-by-side PCR and nasal swab was to test that very thing, to see what the deviation was. The deviation for the state test, which was just under 600 patients, was 3. So we had 3 deviating. We had 6 total positive cases out of 600. Of those 6, 3 Binax test results were negative. The PCR for those came back positive. So overall, it was less than 1%. So we had about over a 98% match between the Binax and the PCR, which is consistent with what we've seen in other states that are also using Binax and have done side-by-side pilots, to include Los Angeles in California, and then also up in Massachusetts, where they did a fairly large population of just over 2,000 side-by-side tests. So we've seen over 90% match between Binax and PCR.
So those were false negatives then, right? Because they ended up being
Correct.
positive? Okay.
Correct.
Out of
they were
600?
asymptomatic patients. Correct.
Asymptomatics?
Correct.
Okay, thank you.
So Bill, we had 2 other questions come in for you.
Great.
One was the results they showed the results on the test strip within 10 minutes. Is that correct?
It's 15 minutes. So the test strip has to be read between 15 and 30 minutes. So after 30 minutes, because the fluid in the specimen well is no longer considered as accurate, so Abbott recommends that window of 15 to 30 minutes.
Excellent. And then a somewhat related question, where and how should the cards get held while you're waiting for the results?
Oh, okay, excellent. Do you mean stored or positioned?
I mean, if you're saying that it has to be read within 15 or 30 minutes, it sounds like the question is, you know, how do you store those? How do you keep them during the 15 or 30 minutes until the results come back? Should they be writing the name of the person on the card? What is a recommendation for handling the testing cards?
Yep, great. So a normal workflow, I'm just going to walk through a workflow. I don't know if we have a particular chart for it, but I'm going to walk through a typical workflow on site. So
I might be able to find one to help you, Bill, from the playbook. Give me a second.
Okay.
Keep going, but
I can talk to it. Yep. So patient participant, test participant, we call them, shows up, registers, checks in with the coordinator who maintains the roster, verifies their name and pertinent information. When they do that, they're given the little foil cartridge or little foil container for the test. That is opened, and inside that is a swab and the test card. They bring the swab and the test card to the observer. The observer, who may be behind a plexiglass screen, that's one of the best practices we've seen at some colleges and other locations, just for extra safety, takes the card from the patient, opens the card, drops 6 drops of the reagent fluid into the specimen well, and passes the card back. The patient then conducts a self-swab, inserts the swab into the bottom of the card, uncovers the adhesive strip on the side of the card and closes the card and passes it back to the observer. At that point, the observer can either write the patient's name on the card, which we've seen done in a few locations, or some schools printed out like address labels with the patient's name and date of birth on it, and they slap that on the card before they begin the process. So that's the other way to mark the card. Once the card is closed for resulting, some observers, we've seen them set up 2 tables, and one table is solely for resulting, and they have an egg timer, and they pass the card back there. They sit there, and the timer's going, and the patient can either stay in that location depending on volume, or go back to their workstation, and that may depend on the context and the kind of work that they're doing, and whether you want to do that. But once that test is past 15 minutes, then the observer reads the result, records the result, and you can have the observer or the coordinator enter that information into the result portal.
And I'll just highlight too, so this image that I'm showing on the screen right now, Bill, I have no idea if this is what you were looking for, but I think it kind of describes the process. There is an entire playbook that Bill and his team have worked really hard to put together that walks through these scenarios in much more detail than we were and are doing right here. And you will also have one-on-one support with someone from Bill's team to help review your thoughts on what your testing plan could look like, suggest workflows and logistics and all of that. So it's not something you should know how to do already. The Department of Health will work in partnership with you to make that happen. And then you'll get just a flag, I guess, that you'll get a whole slew of additional resources once you're ready to start planning what it looks like at your workplace. And now,
That's correct.
and if there are any other questions regarding the what, the how, the why, go for it, and I will be ready to move on to the, okay, I get it. Now tell me what I have to do to make it happen slide.
Hey, Bill, can you hear me?
I sure can.
Question. So we were part of the early PCR testing where the state came out and tested my company. And now we've been doing self-testing for 3 weeks now. And we're testing all of our employees twice a week. The question is the portal. And for everybody that's not testing yet, it's very easy, and everything you just described it's a very, very simple process, and the employees are very comfortable doing it themselves once they go through the process. So for those that are new to doing it, I guess my question is the portal. Is there going to be some enhancements? When we originally set up to do this, it was only going to be the negative, the positives that we were entering into the portal. Now we're entering all the data into the portal. The portal does not save the people's names, so it's like starting over every single time. Is there work going to be done on the portal for companies that are doing repeat entry every time? Is that forthcoming?
Yeah, that's a great question. So we've done some enhancements to the portal, really to make it more a lighter lift for most organizations in terms of entering negative data. So I don't know if you've already seen that or not. In terms of long-term data or storage, the next iteration, I guess I would call it, is enabling companies, organizations, schools to use a CSV file to upload their patient information.
Great. That's what I'm looking for. Because yes, it is a light load relative to what you have to put in there, but it still is, if you have 70 people that you're entering in, it is still 70 people's worth of information that you're entering in. So
right.
It'd be great because I keep everything on a spreadsheet, and just for everybody's, from a legality standpoint, just to document this all, we take pictures of everything. So we just put it on a separate table. One of my people keep a phone out, and we just take pictures of everybody, and we save the pictures in our, twice a week testing. And that just saves the archive of all the test results. So it just is a very simple way, quick way of doing it. And then you throw it into the biohazard bag. So just it was a quick and easy way of versus writing it all down there. And then you can fill in the data on the portal later.
In fact, Steve was just kind enough to share a picture of the one he had from yesterday. So I've got that up on the screen now for folks who had not seen that.
Excellent. Great.
I have a question. Can everyone hear me?
Mm-hmm.
Okay, this is Michelle from Khaleesi Bakery. And we have people that are taking temperatures that we've hired in a separate trailer. So it seems like we would be all set up to do this sort of testing. And we're very excited about it, but very concerned about having a live culture, I'm not sure if that's the right word, but, live specimen, potentially with COVID right there in front of somebody that, may not be a nurse or trained, as you said, very shortly. And what's the liability and possibility that they could be catching COVID from administering these tests?
Yeah, so with proper PPE and risk mitigation measures in place for the testing event, I think you can drop that. I never say zero, right? But you pretty close, right? There's always a chance that an asymptomatic patient would come in and even just by tickling the nose, they might sneeze or what have you. But with self-swabbing, the forward nasal area, really low agitation in the nose, the likelihood of creating aerosolized material that would contact somebody is pretty low, and almost conversational level, right? So if everybody's masked up, and that's why I recommend a plexiglass screen as a way to further mitigate risk for people. When you take temperatures, are they fully gowned, or what kind of protective gear do they wear?
No, they actually are. They have baker's coats on, and
Okay.
We by design have a lot of material right here, and masks and gloves and whatnot. So, I mean, I understand what you're saying, but then that swab is right there in the room with them, right?
Correct. So what I would recommend in terms of handling material, the only time that the observer handles, well, you can actually do the whole process without the observer touching the contaminated or activated card. So if you want to have patients dispose of their own card in the biohazard bag, you can conduct the whole process without an observer touching the exposed card.
So we don't have to keep that result. Is that right?
That's correct. Once you've recorded what that result is, and you don't have to pick the card up to do it. The card can be on a resulting table, a table in front of you, next to you, what have you. Some places I've seen them, the patients sitting there, they both sit there, they watch the results, let's say positive. Okay, now the patient's informed of the status, and then the observer asks them to pick the card up and deposit it in the biohazard bag, and then the surface is sanitized. So the observer sanitizes the surface, the chair, if you even use a chair, and then obviously changes gloves, and the patient leaves, or you proceed with whatever protocols you have in place for a positive case.
And how many other facilities are currently doing this through the Department of Health?
We have had over 200 small and mid-sized employers sign up. We probably have less than 100 actually actively testing right now. We also have Central Falls schools doing this. Smithfield has done some testing like this. And we've just deployed 20,000 additional tests to the Providence School District and trained up a lot of their staff to start this process.
Thank you, Michelle, for those questions.
Something to consider.
Yeah,
sure.
Yeah, in terms of training, we also have the training videos, so it's a good opportunity to kind of see the process. And then down at the Dunkin' Donuts Center, you can go get tested and kind of watch the process. And that's where you'd also go to get personal training, in-person training, and pick up your test supplies.
Yeah, I've actually had to travel the last couple of weeks, so I've had 4 tests in 1 week, and I can tell you how simple it is. It truly is. But then when all of a sudden it feels funny if you're asking one of your employees to do the same process. I don't know why.
True. Yeah, that's why I recommend the self-swabbing and the observer as a way to go.
Absolutely. Thank you, Michelle. Since you asked about people who have had the experience with it, perhaps when we get a little further along in the program, we could maybe ask some of the leaders who are on the call who've been going through this process. I know Steve Lee just mentioned how they've been going through this, and I believe that Peter King of Water Rower also has had some experience with these test kits, so they could answer some additional questions after Bill's going to run through a couple more slides, if that's all right with everybody.
Could I ask one question?
Please.
So, Bill, you're saying that, 2 or 3 person teams would do this, and then the individual employee would sit there for 15 minutes while they're waiting for their result. Does that mean you're testing 4 people an hour?
So it depends on how you set up your testing site. B, what your comfort level is with just collecting a specimen to result and then sending the employee back to the workplace. So what I've seen in schools that test, well over 100 students, we can test with 2 observer recorders, 48 up to about 48 an hour. And the students don't remain in the class. They're podded, right? So they're in, small groups, and they go back to their classroom or what have you. If the result does come up positive, then the school proceeds with the protocols for intervention and notification. But in most cases, they were negative, so nothing further required other than recording the result.
So
Thank
maybe
you.
I misunderstood what you were saying, but so you said 2 or 3 person teams. You got a recorder recording it, an observer observing it. So that one person, so if I walk up to get tested, there's 2 people that are sitting there. And while I'm waiting for the results to come through, are you saying we put that person being tested to the side, and then another person comes walking up to go through? So now you potentially have, I don't know how many folks, 2, 3, 5, 6, 8 in the area that you're testing them in close contact while you're doing the
No, you'd have to sort out, what kind of space you're going to use and how you're going to cycle people through that process. We have some, tips and best practices for doing that. I certainly don't recommend a bunch of people lined up outside the door necessarily in close contact. You can begin the resulting process for the test, and depending on how you set up the timing process. So I've seen a couple of different approaches, as simple as the egg timer, with the start time is written on the side of the card, and the observer has the cards laid out in front of them and they check. Or a more elaborate process where, the cards are arrayed, on the table based on start time. That's what we did at South Kingstown High School. We tested over 200 students in about 3 hours.
We've been doing it for about 3 or 4 weeks, and we just implement this at our regular health check where we would normally do the temperature. And with 2 people, you can test them sequentially. It takes a little bit more time. We let the people, as long as they're masked and protected, they go into the workplace, and we observe the tests. And usually you can tell as the solution with the mucus forms through the card that William talks about. You can tell within a few minutes if that first, being the positive line, is formed. And then, within 10 minutes, if someone's positive, we would extract them from the workplace, give them a information card about what the next process is, and send them home and etc. So it works pretty simple. You don't have to have them sitting there for 15 minutes while this is tested. If you want to be absolutely positive that they're not entering the workplace positive, then you would have to be. In our first round of testing, we found a lot, like 14 asymptomatic people. That was 3 weeks ago. The next week was 3. One of them was a repeat person who had gone off and tested negative through the PCR test. The following week was 0. This last week was 1 person. So I really do recommend it. While we've been measuring temperatures and doing people signing off against checklists of symptoms and stuff, none of these people, all these people would have come into the workplace. All those 14 on the first week would have come in the workplace because their temperatures were fine and they didn't have any symptoms, but yet we were able to catch them or detect them and put them away and quarantine them. Most importantly, because they didn't know they were going to go out into the environment and do whatever they're doing elsewise. So, we're at the workplace, we're helping to protect outside the workplace as well. So, and it's not that arduous. We do 320 people we've got on site. I think maybe our last week's test was 320, maybe more. And the early morning shift we're doing in the entry is over 2.5 hours. So it probably takes 2.5, 3 hours to do that number of people. We prefer to do it all in one day, just so we're kind of capturing people coming in from the weekend. So we thought that was the most logical time, or safest time to test, that we know that everyone entering the workplace for the week. There is an incubation. I know there's reasons why that's not true, but at least we thought that was the safest day to do it on. So we know that everyone in the workplace at that Monday morning has been tested or rejected based on a COVID test.
That's also sending a pretty strong message, I would think, as well, Peter. Thank you for sharing that.
I think so. I think that's that reassurance. I mean, even us doing the temperature check, which we know was, we've had positive tests here, and we've only had 2 people fail the temperature check. So the temperature check we knew didn't fail, but we've kept doing it, from 5 a.m. every morning on a work day, and then and it just does give people reassurance. It does mean that we're doing everything we can, but this is more. This is even more than we can. So being able to detect the people who are positive and send them away keeps us even safer, because we knew the temperature check didn't work, and we knew that we didn't have it in the building. And our aim was to if it came into the building, to mitigate any spread, because we knew that what's going outside, we didn't have any control out of, so it was going to come in. But this does give us an ability to control what's coming into the building, which is very important. So I do strongly recommend it. While it's arduous, and I take the point earlier on about the record keeping is having to put all those 320 people in every day, every week rather, is with the test results is a bit arduous. But the people do then get a text message through the DOH that kind of says that gives them a negative result, which they do kind of like as well, because that's something tactile that they can show to people, so. But yeah, highly recommend it. It's not that difficult. It does take some effort, obviously, but I think it does give huge reassurance to your workforce. And it does do the safety thing as well. It does detect people who would otherwise not know about it and would be prone to spreading it further, not just within the workplace, but amongst their family and the greater community. So it's very helpful that we can take a pocket of people that we know their names, addresses, and know that they're contained and they're always going to be around each other, and test that body and weed out the people who've contracted it logically outside the workplace.
Thank you, Peter.
Yeah, those are great points. Can I ask a question?
Sure.
Do you make it mandatory, or is it an opt-in process in your organization?
Yeah, it's become mandatory, I guess, because maybe on stern tones, but I must say there was some original pushback with some silly objections in reality, but and there are still 2 people within the organization, and we've got 4 different facilities, manufacturing facilities, and there's some property management people that we're testing, which is under the same organization, and some construction people as well. So we test all of those, and some of them were very happy about it. There were 2 people in that whole group that didn't want to test. They were in the landscaping end of the property management division. So I won't say it tells you something about landscapers, but anyway, we won't say that. So are there any landscapers on? But no, well, and they're all outdoors and stuff. They're all outdoors and in the open air and stuff like that. So maybe that's why they did, and they were less at risk. So, but there were in the initial test, people say, I'm not too sure. And their initial reluctance, amazingly, was saying, well, if I test positive, what happens? Do I have to go home?
Yeah,
and who's going to pay me and all that? So, we've been very good with the CRA program and covering for the 80 hours, and then going beyond that and accruing it against their vacation or sick leave kind of entitlements and stuff, and banking that so that they're not without money. So, so when we explain to them that they're not going to be out of pocket, I'm going to be out of pocket if anything happens, then and it's a matter of actually protecting the person who's standing next to you, very much so, that that, and then with one person, a new employee, actually week 1, week 2, week 3, and she tested week 3. That was the only positive we had, just out of the blue. But so somewhere she contracted it through away from here, one assumes, and had no symptoms. So it's very important that she knew that, and for the people very close to her, her loved ones knew that as well, because she could have been infecting them. So
hey, Peter, can I ask you a question?
Sure, Ralph.
Since you're already doing this, have you had where you did the test at work, it tested positive, you sent people home, they went and got another test, tested negative, and now they're angry because they lost pay and all that stuff?
We've been paying them, Ralph. So, we've been covering them on the FFCRA entitlements if they still had them, and we've been paying them anyway by accrued annual leave. There was one woman who everyone tested. So there is a 220 number. I think we could probably share that on, Erin, I could pass it to you, the document we printed out, and you could share it with the folks. And they can go, so if you test positive, you go to this 220 number, because one of the problems, if you line up with your doctor or whatever, it can take 2 or 3 days to test positive, which is a bit of a drag. So this 220 number will will entitle you to go and you get tested. Everyone who's rung that has got tested same day, because it's to do with this asymptomatic testing. I think, William, you could probably go into that more. But all those people have tested. And then we had one gal who tested positive on the first week, proceeded to get 2 negative tests, and then came back after that and tested positive again under the Binox test. So that's one of those flyers that William said. And she went and tested again under the PCR and got negative again. So we allowed her back in the workplace under the recommendation of her doctor, saying that there were certain contaminants or whatever, dead cells or whatever in the nasal passages, which was probably the reason it was triggering it. But I'm not a doctor, but that's what he said. So she came back to work, but she did have, she got tested 5 times within a week. So
Interesting.
yeah, it is interesting. And then this isn't, there are some flyers there, but we had one guy who tested negative by PCR and tested positive again, so we sent him again for a negative PCR. So our line, our hurdle is just saying you've got to have a negative PCR test.
Yeah, and that confirmed that kind of matches public health guidance from the state. I think that's an interesting case. And makes a strong case for in-person training too. So I would recommend, with this program, absolutely trying to get the in-person training, and we can help facilitate that on site if needed for some cases. So
our guys are getting, at 4 weeks in, you got 1,200 tests under your belt. You get there's a lot of intuition developed. So, but it's very easy, as William says, and it's pretty simple and very, very quick, but it does give a lot of reassurance to the employees, which does add to the sense of health in the organization, I guess you're saying, but also very importantly carries that asymptomatic detection to the greater benefits of the community, I think.
Yeah, in the chain, if you think in terms of the chain of test, identify, trace, and then isolate, to shut down spread, this is that first engagement, that first step, and it's about behavior modification in many regards.
And I think that's why we've been so thorough in just keeping all these things that we know probably aren't, temperature checks and the signatures and stuff, keeping up to all that, and the deserialization we do before shift start and stuff. But while there's a question, we do also, there's a Failix test. We do COVID surface testing as well once a month, just on different surfaces and stuff randomly during the day, and we detect to see if the COVID virus anywhere, because you can't see this damn thing. You can sterilize as much as you want. You don't know whether it's there or not. But with 2 things is with this Failix test and with this Binax test, you can detect it in the workplace, which does give you reassurance. But I think the whole procedure and the whole even the way we all manage traffic circulation patterns at shift changes and stuff, it does grind things in. You can see behavior changes. I can see in 15 years time, people are still going to be standing 6 feet apart because of these times. But you can see how ground that is and how people are, and you see the difference in the new employees. We bring in new employees. We're growing, thankfully. We bring new employees. It's you can see the time it takes over a couple of days to have that adjustment in their behaviors.
Right. Bill, we had 2 questions for you that are kind of related to the behaviors and related to a mention that you made about providing assistance on site. One question was that if a company does not have staff that are willing to be the observers and recorders, willing to kind of be the administrators of the test, not that they're actually physically administrating, but that they're administrating it. Do you have any recommendations on medical professionals that they could possibly hire to come and do that role for them on site?
Yeah, so I don't have any. We can point out some companies that do this, are familiar with it. I just want to be careful. I don't want to advocate a certain company over another one. However, we have had employers who do outsource this. And that may be health professionals that already service their organization, if that makes sense.
Yeah, I understand. So definitely, if you have any recommendations, if you can filter them through us, and we'll make sure we send them out to everybody who's attending today. So that's a great question. Because there was a related question of when you're asking kind of team members to volunteer, as an observer or a reporter, are there any kind of tips that you have for helping people step into that role? I know, Steve Lee, you said that you actually do it yourself. You are the observer reporter, and you do about 50 an hour at Meridian. Is that correct?
Yes, so myself and one other manager are the people that do it, and we've got a small enough company that I felt it was important that they see me as a person that's responsible for doing it. And we have two people come into the room. There's two of us that are doing the testing, the employee swabs. We have a room where 2 doors, so they enter in one door, they exit the other door. They hold the whole swab themselves. They put it onto a different table, so I'm never touching a swab. I take the responsibility. My employee does not ever touch the swab. I take the responsibility, but I do glove up. We use sanitizer in between. We sanitize the pen in between people coming in. And those 2 employees get 2 more employees. So we have 2 people waiting, 2 people in the room swabbing. It's a big enough room that they're off to the side. So there's social distancing is not an issue at all. Nobody pulls their mask off all the way. People do sneeze every once in a while. So Bill is correct there. We were getting weekly PCR testing. So people are used to putting it deep down their nose. So our swabbing is probably deeper than most will do that didn't do PCR testing, because my employees were used to it and now they're doing it themselves. But we do it in an hour. I let everybody go back to work. I use my Apple Watch to set Siri for every 15 minutes, and it rings me, and we then take pictures. And then it's all documented. And at some point within a 24-hour period, the data gets entered into the portal. So it isn't a problem, and everything that has already been said is 100% true. The employees feel that it is a safe workplace. If somebody is sick still because they failed their pre-screening and they still get a negative test, we then send them out for a PCR. If they get a positive, we send them out for a PCR. We also, if we do have a customer that's on site for more than just a quick visit, we test them as well. Customers that are in our building for more than just a 20-minute visit, they're there for an all-day work printer. They could be on press for days. They get tested every day that they're on site. Whereas the rest of my employees, we test Tuesdays and Fridays. So we try to every 3 days is what we're trying to separate. So Tuesdays and Fridays, we do all of our testing.
Excellent. These have been great questions. I'm going to ask people to please keep them coming in the chat, but we're going to let Jillian and Bill go back with their presentation. So please keep those questions coming. If we can't get them in this session, we will make sure to try to push information out afterwards.
And this pivot right here is simply to the what's next and what do I actually have to do to get this off the ground. So that's what Bill will review quickly here.
Yep. So to onboard into this program, the state has a couple of documents that we send out to familiarize the company with the requirements from the state. That we have a fairly straightforward, simple MOU. We've recently upgraded it with some modifications based on feedback from different communities. The CLIA waiver, for some people, and I'm sure folks already using the test can describe the process, but it's fairly quick. It's not a very complicated document. The team at Commerce and Rhode, we're going to develop a webinar to sort of walk everybody through the steps to simplify it. And then all of those documents then come back to your point of contact with the state, and we'll begin the process of setting up your account. And sort of the last step there is setting up a reporting account, and that's a fairly straightforward process. Usually takes less than a day. And all told, that onboarding paperwork chain takes between 5 to 7 business days. So from the time you get the MOU to the time your reporting account is set up and you receive that email to begin the reporting, is usually 5 to 7 days. If you request on-site training, your point of contact with Rhode, your account manager, will help set up training, probably at the Dunkin' Donuts Center, with some of the National Guard staff who use the test there. We also have training videos, both from the National Guard and from Abbott, that describe the process. And again, as folks who've already used it can tell you, it's a simple process. There's not a lot of rocket science to it. It's easy. And then we're available to help field any questions about the creation of your testing plan. But it sounds like you have some great resources out there who are already in the process of doing this, who can provide you the best lessons learned and techniques that they're already employing to help you get off the ground. And then one point I'd like to again reiterate, the best testing programs rely on a lot of stakeholder communication, not just to your employees, but also across your management staff, and then in some cases out to families and other community members. So, developing a communication or an engagement plan is a key internal step to being successful with this. And then once you're set up the gates and you're ready to go, picking up the tests is a simple process. The loading dock will provide you with the information and connect you with our inventory team, and the inventory team will prepare your package of tests based on the initial quantity of tests you anticipate doing. And then once you begin that testing process, we will probably revise guidance a little bit on when to request resupply, but that resupply is centrally located at the Dunkin' Donuts Center. That's the state hub for Binax Now tests. And the final point for getting this process rolling is the biohazard disposal. We have the biohazard bags and boxes at the Dunkin' Donuts Center, and you'll get your first bag and box with your initial draw of tests. And then we have the contact for pickup, and we'll establish a cadence for recovery of those full bags. Now, your average bag and box can hold about 1,000 test cards. So it's not the kind of thing you have to have picked up every day. If you have a secure place, you can store that. I have seldom seen a small business or even a school fill one up in a week. I'll pause here if there are any questions.
I haven't had any related to this specific section, no.
Great. All right, super.
Cool. And then I think the last piece we have here is just some key questions, some of the more popular questions that we heard. And I know that some of you submitted questions regarding, one thing that is not referenced on the screen right now is regarding liability and HIPAA. And so I think regarding the liability, a lot of that will be covered in the MOU. But Bill, if you want to speak to those 2 points, there were a couple companies who submitted those questions. So I think circling out on what liability do I assume and how do I make sure that I'm handling health information the right way would be great.
Right. So specifically the liability, under the agreement, the MOU, volunteers or observers and recorders within your organization and the company itself is conducting this testing under the executive order, the blanket executive order for as an emergency situation. So it's sort of an extension of emergency management work. And so that picks up the liability from your team, and they're covered underneath this emergency order. In terms of HIPAA, so your normal personal protection of personal information and medical information applies. There's been a lot of care and thought taken into how to balance the information and data collection needs of the state with disseminating these tests widely in the community. So I think we've addressed most of the concerns in terms of the data fields that are available for reporting outside of the organization.
Perfect. I think the other piece I would love to highlight on this page specifically is that I think, as both Steve and Peter covered, this testing does not replace active screening in any way, shape, or form. Regular screening should be happening every single time someone walks into a workplace. We want to be extra careful that if someone comes in and their temperature is high, but they test negative on here, like, we're still paying attention to symptoms, and active symptoms are taken into consideration if someone's coughing and they can't say no to all of the questions that are on the screening form. We don't want to use this as the sole determinant to make a decision. We want to make sure that we're taking the totality of evidence in front of us with the active screening that's still happening. And so that's just a key underlying point to reinforce. And then I think other than what's up on the screen, if there are other questions, I know that we will be following up with Polaris to make sure that they have the MOU, that they have the empty CLIA waiver. Before we record that webinar that Bill referenced, there is an example CLIA waiver form that we can also include that helps you figure out exactly how to fill it out the right way. And we'll also follow up with some additional documentation, such as a one-pager and an FAQ document, so that you, regardless of what part of the organization you are in, can help communicate this more widely to the leadership to get it started. So those are just some bottom line question or comments, I guess, and takeaways, but we still have a few minutes if anybody has anything else.
Hey, Bill, this is Stephen Lee. One question that did come up from some of my staff this week in testing: the new strain, does the current self-test still cover the new strain, and is that going to be an issue? Has that been tested? I've done some research on Abbott's website, and I don't see anything written about it, and don't really have a good answer for the employees.
So that's a good question. I don't have a good answer for you there either.
Okay.
The state lab has looked at it. Right now, there are no red flags up about detection, but the state lab is digging into a couple of samples to see if there are any impacts for how we're doing testing now.
Okay.
So that's as far as I have on that.
Okay.
And I will flag that this is a more concerted effort with like a key list of companies that we're onboarding and working through for the next couple of weeks, but this program will eventually pivot to be open to everybody, in which case there will be a more substantial framework of support for people and a call center and a dedicated space on a website. So additional information, updated FAQs, et cetera, will continue to be pushed as it gets developed. Right now, we're sprinting to make sure that the biggest players get our full attention before we pivot to open it a little bit more widely. So when we get information about that, Steve, we'll be sure to make sure that it's included in those public facing places, and can make sure we stay in touch with Polaris as well to communicate any significant updates.
Great.
Yeah, it's a super question though. I'll take that back to Dr. King at the state lab.
Yeah. So is there a maximum amount of tests? Like, for instance, you know, maybe Khaleesi might be bigger than some of the smaller employers that are there, but certainly not as big as the schools. Is there I understand they come in packs of 40. So, I mean, if we decided we wanted to test 3 times a week, I mean, is there a limit at some point saying, you know, you've taken your allotted amount?
Not really. Not right now. I don't want to say we're at the point where I'm going to like start throwing these off the back of a truck or anything, but you know, we are pushing them aggressively out into different populations. So we just gave, like I said, 20,000 out to Providence schools. We have over almost 2 million in the Dunkin' Donuts Center now. We're, you know, given the state's population and the fact that the state was selected as one of the pilots for Binax, we got a generous break of supplies from the federal government. We're getting our last shipment, our last free shipment shortly, in the next week or so, I think. After that, we won't get any more shipments, but we'll still have surplus quantity on the ground.
Okay. And then a different avenue, but I mean, any word on the vaccine? And if we get to a point that we can be doing this sort of outreach for the vaccine with our employees?
Yeah, so I don't work in the vaccine work stream. However, they're obviously closely associated. The one point I would make in relation to the question I do get frequently is when we get vaccines, into our particular affinity group, community, school, what have you, do we need to continue to test? And for the time being, the best medical advice from Rhode is yes, anticipate testing in parallel with vaccine distribution.
Mm-hmm. Sure.
We don't have any other questions that have come in, but Peter King did share with me, and I can put it up on the screen quickly, the kind of if you test positive handout that they have been sharing with their team. And so I will make sure that this goes out into our kind of follow-up information that we send out. But I just want to make sure that folks get a chance to see it, because this is a great way to kind of remind people, as Jillian said, we still need to be doing all of the things. We still need to be doing masks and spacing and cleaning and making sure that we are isolating when there are challenges. So I'll make sure that's shared. And so thank you very much for sending that to us, Peter, so that we could share it with more. Are there any final questions before we go? I want to be respectful of everybody's time.
I have about one more thing too. So there, for everybody, and we're like I mentioned the sprint, and I am not kidding about the sprint. This team has been sprinting 25 hours a day for the past week, and more since however long a lot of you have already been up and running. But we will also be able to provide some resources for how to talk to your employees about this, so that you don't have to know how to do that yourselves. There is a sample memo that is a positive or negative result that we can share. We plan to draft some templates for emails and posters, and here's exactly what we're doing. And we're trying to help you communicate it to your folks. It sounds like Peter has done a lot of the work himself, which is awesome. But the state has resources that they will also be funneling towards you guys to make it easier to communicate about it and get the buy-in from your teams, so that the rollout is easy. That's it.
Jillian, if you get that to us, we'll send it out too.
Perfect.
Yep.
All right, I think that's it. Kathy, any final words before we say goodbye to everybody?
I just want to thank everyone for coming, and especially to the state for offering this program, and the Department of Commerce and Department of Health for putting this on. I think it answered a lot of questions, and I certainly am excited about the program.
Hey, thanks to everybody for the great questions and feedback.
Thanks, everybody.